Okay, so let's go on and talk about uh, some different conditions resulting from a spinal cord injury. Okay, so the first one we're going to talk about is spinal shock. So the way I think of spinal shock is what is happening beyond where the spinal cord has been injured to the motor and sensory nerves um, below the injury. Okay, so it's all about the spinal cord and the motor sensory nerves. It's got nothing to do with blood pressure or the sympathetic system. Let's just focus on that. Okay, so we have a spinal cord injury. Let's just say at T10. Okay, thoracic level 10. Okay, so what's going to happen? Well, you're going to have motor paralysis distal to T10. Okay, so you're going to have paraplegia. You won't be able to move your limbs, your lower limbs, that is. Okay, you're going to have a sensory level. And we look for sensory levels on the body of someone with a spinal cord injury. So we'll go along and we'll ask them, when do you feel us touching you? Okay, and we'll look for that sensory level because below the spinal cord injury, they won't have any sensation. Okay, so both of those are part of spinal shock, right? The motor loss to the muscles and the sensory loss because of the spinal cord injury. Now, when we're talking about spinal shock, we often refer to the bladder as well because patients get urinary retention. So the signals from the bladder that go to the spinal cord, um, they don't get processed, and then for the signal to return to the bladder for a contraction of the detrusor muscle of the bladder. So often they go into urinary retention. Okay. What happens to the reflexes? So distal to the spinal cord injury, the reflexes initially, typically for the first few days or weeks, they're completely flaccid. There's no reflexes. Okay, so if we were to check the knee or ankle reflexes of someone with a T10 injury, they would be completely absent at the beginning, uh, the initial days to weeks after the injury. It's typically days. Okay, so areflexic, no reflexes at all. What happens to those reflexes over days to weeks? They become hyperreflexic. Okay, so those reflexes that weren't responding in the first couple of days have now become hyperreflexic. So that when we check the reflexes, they have an overly brisk response now. And that's the way they're going to stay permanently. Okay. Now, in terms of the motor and the sensation, the sensory levels, that is totally dependent on the spinal cord injury and the extent of the damage. Okay, so if there's a complete transection, a complete cut of the spinal cord, then the motor paralysis will be permanent, and the sensory level, where they're unable to feel anything, will be permanent as well. Okay, in partial spinal cord injuries, some of that will return. There's no way of knowing how much of it will return at the beginning because there's inflammation around the spinal cord, and that's affecting which level and which disability is present in front of us at the moment. As the inflammation starts to go down over weeks to months, they may get more motor function and they may get more sensory function. Okay. The other thing that changes, so we mentioned that the tendons change to become hyperreflexic, and the flaccid muscles of the legs, for example, become spastic. Okay, they're not completely flaccid anymore. Um, so they're still paralyzed, but they have spasticity to them. Okay, increased tone. Okay, so and that's why we have to use certain muscle relaxants in patients with spinal cord injuries to try and help them maintain some range of motion to their joints and also to stretch out the muscles. Okay, so let's move on to the next one, neurogenic shock. So neurogenic shock typically occurs with cervical spine injuries all the way down to around thoracic level 6. Okay, so T6 and above. And what happens here? Well, when there's an injury from T6 or above, the, the sympathetic nerves have been injured. So if you remember, the sympathetic chain and the sympathetic ganglion go along and follow the vertebral column. Okay, and when it's injured from T6 or above, you don't have the sympathetic system sending out its signals any longer to the heart, to the blood vessels, to the sweat glands. So what's going to happen? Well, with reduced sympathetic stimulation to the blood vessels, you're going to get vasodilation and hypotension. With reduced signals from the sympathetic system to the heart, you're going to get bradycardia because the parasympathetic system is having more influence. With less sympathetic stimulation to the sweat glands, you'll have reduced sweat, right? And this can be a problem because when you're vasodilated and you're not able to sweat, you can have body temperature regulation problems now, okay? So think of the neurogenic shock as the injury that's occurred because now the sympathetic chain has been injured. And that's going to impact the blood pressure. It's going to be low. The heart rate, it's going to be low, which is really counterintuitive. Low blood pressure and low heart rate, they don't usually go together. Okay? The decreased ability to sweat, the decreased ability to thermoregulate. And the other one that can occur is priapism, which is a sustained erection for an abnormal length of time. Okay, and that needs to be addressed because a sustained erection can lead to ischemia of the penis. Okay, and it's occurring because there's so much vasodilation because the sympathetic nervous system is no longer innervating the penis. So there's vasodilation. Okay? So neurogenic shock, think the sympathetic nervous system has been injured. And neurogenic shock typically occurs from T6 and above in terms of the sympathetic nervous system. Okay? So what can we do for neurogenic shock? Well, these patients come in not only with the spinal cord injury and the loss of motor and sensory function and the loss of their deep tendon reflexes beyond or distal to the spinal cord injury, they now have low blood pressure and bradycardia, right? So these patients often need IV fluids and they may need atropine to increase their heart rate, and they may need some medications to raise their blood pressure, such as norepinephrine. Okay, they're lacking the sympathetic system, so sometimes we have to give them medications to vasoconstrict their blood vessels. such as norepinephrine. Now remember that the parasympathetic system has not been injured in this spinal cord injury. The parasympathetic system, a lot of it comes from cranial nerve 10. Okay, and the vagus nerve, which is cranial nerve 10, is coming off of the brainstem, right? So it hasn't been injured in this spinal cord injury, and that's why it's able to influence the heart still, and the blood vessels, right? And what does the parasympathetic system do to the heart? It slows it down. What does it do to the blood vessels? It will vasodilate them even more, leading to hypotension. Okay? Okay, so let's talk about the last complication here of a spinal cord injury. And this one's a bit strange, and it might take a bit of time to understand it. So it's called autonomic dysreflexia. Okay? So what is this? Well, let's just say that you've had, or a patient's had, a spinal cord injury, and it's typically, again, T6 or higher. And why is that? Because of the sympathetic nervous system that's been injured at T6 or higher. Okay, so you've had an injury. You have spinal shock. You may have had some neurogenic shock at the beginning. Remember, neurogenic shock may not be permanent, right? It'll correct itself over the span of weeks. And we already explained, or I already explained what happens to spinal shock, where your nerves become, or your reflexes become hyper-reflexic, and your muscles become spastic instead of flaccid. But a lot of it depends on the degree of the spinal cord injury. Okay? So autonomic dysreflexia is where you have some kind of painful stimulus below the level of the spinal cord injury. Okay? So what kind of painful stimulus do you have? Let's say your bladder is full and you can't feel it. Okay? Because remember, you have no feeling below the level of the injury. Or you have some kind of tight dressing or tight pants on your legs, or you're severely constipated. Well, any of those is going to send a signal to the spinal cord, right? And the spinal cord below the level of the injury is very, very irritable, especially the sympathetic nervous system, which has been injured, remember, from T6 or higher. So the lower part of it doesn't really communicate the same way anymore. So when these impulses come in to the spinal cord from constipation, a distended bladder that you can't feel, a tight dressing on your leg, the sympathetic nervous system sends out tremendous amounts of signals from the area below the spinal injury. Okay, so what's going to happen? Well, when the sympathetic nervous system sends out a lot of stimulation below the spinal injury, well, you're going to get severe vasoconstriction. That's going to lead to hypertension because there's going to be vasoconstriction all over the place to your arterioles. Okay, what will the severe hypertension cause? Well, likely a severe headache and potentially leading to a hemorrhagic stroke, right? So autonomic dysreflexia is not a good thing because of the severe hypertension. Okay, so you have baroreceptors in your carotid arteries, and they can sense this very high blood pressure, and they send a signal to the brainstem, and the signal is for more parasympathetic stimulation to try and reduce this severe hypertension. Okay, so what's going to happen when the parasympathetic nervous system is trying to reduce this severe hypertension? Well, because the parasympathetic system is still completely intact, it can cause bradycardia to the heart, and it can cause vasodilation to the level above the injury. It'll cause pupillary constriction, so meiosis. It'll cause flushing above the level of the injury because of all the vasodilation, and nasal congestion or even increased saliva can occur. And this is all because the parasympathetic nervous system has now been turned on to try and reduce this blood pressure. Okay? What's happening below the level of the injury? Well, the sympathetic nervous system has gone into overdrive. The skin is pale, it's cool, it's clammy. That's all sympathetic nervous system stimulation. You may have goosebumps below the level of the injury, along with the pale, cool, clammy skin. Okay? So you can see that below the level of the injury, there's excessive sympathetic stimulation. Above the level of the injury, the parasympathetic system has been turned on due to the hypertension to try and reduce the blood pressure, but in the process, it's caused vasodilation, pupillary constriction, flushing of the skin, nasal congestion above the level of the injury. Okay? So how do we deal with this? Well, we look for the cause of the stimulus. So the cause of the pain. So is it a blocked Foley catheter? Is it a tight dressing around the lower leg? Is it severe constipation that's sending these signals into the spinal cord below the level of the injury? And we try and correct them. Okay? At the same time, we often have to use antihypertensive medications to get this blood pressure down, because these patients have such severely elevated blood pressure, it can lead to a hemorrhagic stroke or a heart attack because the blood pressure is so high. Okay, so hopefully that makes sense. This autonomic dysreflexia that's been triggered by some kind of painful stimulus below the level of the injury.
Okay, so spinal cord injuries. Two most common areas are cervical and lumbar, and they're much more mobile than the thoracic um, vertebra. So especially the neck. I mean, really, it's like a pedestal that holds the head. So it's very mobile. So it's more at risk for injury. The thoracic spine is a more rigid structure. It's held together by the 12 ribs on each side, plus also the ribs. Most of the ribs go around to the front and attach to the sternum, so it's much more rigid. Injuries above C3 to C5, definitely if they're C3 or above, there's no respiratory function because the intercostal muscles that help with breathing and the diaphragm are no longer contracting, C3 or above. Anyway, C5 to C3 is the diaphragm. So if you're below C5, you'll still have your diaphragm going up and down, contracting, helping with respirations, but you won't have any of your intercostal muscles to help. So you might be short of breath, but hopefully you'll still be breathing just with the use of your diaphragm. Cardiac. So we put cardiac here because just so that you knew. So T4 and above. So remember the sympathetic chain along the spinal cord from T1 to L2. If you have a spinal cord injury T4 or above, the little sympathetic fibers going to the heart are affected. So they will no longer transmit sympathetic signals to the heart, which will result in bradycardia. Okay, so what can we do to prevent or to treat a spinal injury? And really, we can't do much about the initial primary injury. That's already occurred, unfortunately. So a lot of our treatment is focused on avoiding secondary injury. And the first one there is immobilization. So if we think that someone's been in an accident and we just don't know what's happening with their spine, uh, we'll, we'll, we'll immobilize the patient until we can examine the spine further. So this is really important with the neck when someone comes in, for example, and they need to be intubated or they're being moved around. Usually someone's responsible for making sure the neck and the head aren't moving a lot, or we'll put them in a cervical collar. So immobilization critical to reduce further injury. So spinal board initially, and a rigid cervical collar. Okay, so now obviously we don't want to leave people a long time on a spinal board, so we will transfer them safely to a stretcher. The cervical collar we can leave on until either we have to, it's very hard to open the mouth or try and put an airway into someone that has a rigid collar on. So we have to remove the rigid collar, even though we haven't ruled out an injury to the cervical spine. And then someone is responsible for holding the head and neck firmly and not allowing it to move while we do other procedures. Okay, so next one is prevent hypoxia and hypotension. So a wounded spinal cord or brain are very sensitive to low oxygen or low blood pressure. So we keep a very close eye on making sure that that the brain and spinal cord continue to get blood pressure supply and or blood supply from a normal blood pressure, and that the oxygen levels in the blood are high enough to oxygenate the cells. So that's really important because cells have already been injured, and now we don't want to secondarily injure them further. And it'll be neurogenic shock that can cause this hypotension, or one of the causes. I mean, they might be hypotensive because they're hemorrhaging else from another wound, but neurogenic shock itself can lead to low blood pressure. So need to watch it closely. And what's the other problem? So you can get hypotension from the neurogenic shock, assuming you just have a spinal cord injury, no other injuries that are causing hypotension. But as well, you can get hypoxic because you may have a spinal cord injury that's higher, say in the neck, that's impacting your respiratory function from the use of your diaphragm or the intercostal muscles. Now, years ago, there was this constant debate about using very high doses of steroids, glucocorticoids, intravenously with spinal cord injuries. We thought that they would improve or really help with the inflammation in the area, and that might improve spinal function later. And this went on for years, to the point where different centers had different opinions. And finally, after many studies, we no longer use IV steroids with spinal cord injuries at all. In actual fact, more people were getting skin breakdown and skin ulcers with this particular treatment. So no steroids intravenously with spinal cord injuries. So always keep in your mind with any injury, just revert back to A, B, C, D, E. Okay? Airway, breathing, circulation. Disability is, once we've dealt with the first three, is assessment of the neurological system, disability. And environment is remembering the fact that your patient has been in an injury somewhere. It could be in the middle of the winter, could be very cold out. So they've been in some environment where the injury occurred. And also they're now in your environment where it may not be warm enough for them. So we always keep in mind that patients can become hypothermic very quickly. We're pouring cold fluids into them intravenously. We might be giving them blood products. So all these interventions can make them cool down very quickly, and that's not a good thing to be hypothermic and having been in a trauma. So we really keep an eye on their temperature and make sure that they stay warm with blankets and other maneuvers. Okay, so let's move on from the spinal cord and talk about infections, inflammation of the brain. So a brain abscess, whenever you see the word abscess, it's just a collection of pus and typically bacteria, um, wherever it is. So a soft tissue abscess, it's a collection of pus in the soft tissue. A brain abscess, collection of pus and infection in the brain. So bacterial meningitis. So the meninges are the layers that are covering the brain. So it's not within the brain itself. It starts in the layers of the brain, the meninges. So bacterial meningitis. You can get viral meningitis as well. People typically recover very well from a viral meningitis, inflammation of the meninges from a virus. Bacterial meningitis is much more aggressive, and these people are typically extremely ill with septicemia, so low blood pressure. There's bacteria flowing through the blood. There's bacteria that's invaded the meninges surrounding the brain. We do have some vaccinations for pneumococcal. So pneumococcus is one of that bacteria that can cause bacterial meningitis. Meningococcus was feared for many years. Children would acquire this disease, meningococcal meningitis, and it would be deadly most of the time. And then Haemophilus influenza B, which is the Hib, Haemophilus influenza B. That's another, I know it says influenza, but that's another bacteria. And there's vaccinations for all of these, okay, in the childhood years. Now, without antibiotics years ago, there was essentially 100% mortality rate. It's not survivable. And but now that we have antibiotics, if we can get them, if we can get it recognized and diagnosed, and then we'll start intravenous antibiotics quickly. And often steroids are sometimes used because there's such an incredible amount of inflammation around the brain in the meninges that steroids are added to try and reduce the inflammation. And of course, antibiotics are used to try and kill the bacteria. So what are the symptoms of bacterial meningitis? So typically it's a high fever, severe constant headaches, and often you're confused, nausea and vomiting, neck stiffness. That would be a very concerning feature in the setting of fever and headache. So nuchal rigidity is neck stiffness, and photophobia. When we shine a light into a child's eye or an adult's eye, and they immediately close their eyes or move their head away, that's photophobia. It's painful constriction of the pupil. Okay, they're photophobic. So that's bacterial meningitis. Now, so viral meningitis is just a much milder form of it. And sometimes we'll treat viral meningitis uh, with, uh, with antiviral medications. It's not typically deadly like bacterial meningitis. Uh, you can get similar symptoms, but they're not as severe. So you can get low-grade fevers, you can get headaches, you can have some neck stiffness, you can be photophobic, but you're typically not severely ill like you are in bacterial meningitis. Okay, encephalitis, that's inflammation of the brain itself, so of a part of the brain. So acute encephalitis is something that's happened, within hours to days, usually when we call it acute. Sometimes weeks, but typically you're going to present earlier because of the symptoms. And viral, the typical viral encephalitis is from herpes, and it can be at any age, and herpes can actually infect and invade the neurons, uh, and create an encephalitis. So we will, if we suspect this, we will start intravenous acyclovir or another antiviral medication. Okay, so inflammation of a portion of the brain, often non-specific symptoms, fevers, headaches, photophobia. Sometimes they're a bit confused, and as I said, antivirals are used as the treatment for this. Not usually deadly. Most of the time, you recover from it, from the antiviral, and also your own body fighting the viral infection.